Hi, this is Nurse Inga, and in this video we're going to discuss somatic and dissociative disorders. Somatic disorders are syndromes where the person has symptoms that cannot be explained medically, and they're associated with psychosocial distress and long-term seeking of assistance from healthcare professionals. Often their symptoms are very vague, overly dramatic, or exaggerated in their presentation. And these patients tend to spend an excessive amount of time and energy worrying and concerning about their symptoms and seeking health care. The cause of somatic disorders is not entirely known, but it appears to be associated with childhood trauma or a previous severe illness. We do consider these to be maladaptive ego defense mechanisms. Because the person has difficulty expressing the true underlying emotions and uses these somatic complaints as a way to divert the attraction or focus from the actual stressor. The learning theory states that because there was a positive reinforcement of the illness, the person turns to the illness during times of stress. This allows the person to avoid things that they don't like or they don't want to do, which is a primary gain. They get attention, which is a secondary gain, and it relieves some of the problem by shifting the focus away from the problem onto the somatic complaint, which is a tertiary gain, and then they don't have to think about that stress anymore. Somatic symptom disorder is multiple physical symptoms that cannot be explained medically. Excessive and disproportionate thoughts, feelings, and behaviors related to the seriousness of the physical symptoms. They may or may not be associated with an actual medical problem, which can make diagnosis very challenging. And the high level of worry over health becomes the central focus in the person's life. Illness anxiety disorder is the unrealistic or inaccurate interpretation of physical symptoms or sensations. Anxiety related to non-existent or very mild physical complaints. The person may have a small problem and blows it way out of proportion, or may have excess worry or anxiety over developing a problem that they may not even be at risk for. Conversion disorder is where the person converts anxiety or stress into a physical symptom. This can present as paralysis, difficulty or inability to speak, blindness, pseudocyesis, which is a false pregnancy, difficulty moving, any of these things. The symptom is very real to the patient, but is not caused by an actual medical problem and usually resolves itself within a few weeks as the stress dissipates. It may allow the person to avoid a difficult situation or the source of anxiety, which again is a primary gain. It allows the person to gain support without having to face the source of anxiety yet, which is a secondary gain. Fictitious disorders, also known as Munchausen's but renamed by the DSM-5, are the intentional feigning of physical illness. A fictitious disorder by proxy, or Munchausen's by proxy, disorder is when you impose that fake physical illness or injury onto another person or even a child. When you are caring for someone who is experiencing somatic disorders, it's important to first do a very thorough and well-documented physical assessment to rule out an underlying medical cause. Do not spend a lot of time discussing the physical complaints, but do encourage the patient to verbalize their anxieties and fears. Pay attention to patterns of exacerbation and what might be causing them. Talk to the patient and family about ways to maintain healthy relationships and coping strategies. Treat the signs and symptoms as you would any other medical disorder that had the same signs and symptoms, and in addition, consult psychiatry. It's important not to discount the patient's disorder, as that will increase their anxiety and make their symptoms worse. Be honest and compassionate, and let them know that their well-being is important to you without feeding into the delusions that they're experiencing. Involve the patient in goal setting, When you do your thorough assessment, again, do not reinforce the somatic complaint. Encourage expression of feelings rather than the complaint itself. Dissociative disorders are different from somatic disorders. In somatic disorders, the stress is manifested physically. In a dissociation, there's an unconscious defense mechanism in place that separates identity, memory, and cognition from affect. So basically, ideas and memories about themselves are separated from their current personalization or affect. Dissociative amnesia occurs when the person experiences a traumatic event and then is unable to recall important personal information. This can be localized amnesia, where they can't recall events related to a specific trauma. Selective amnesia, where they can only recall certain events for a specific time after the event. Or generalized amnesia, where they forget their entire self-history or identity. A dissociative fugue is similar to dissociative amnesia, where the person suddenly, unexpectedly travels or has this bewildered wandering and cannot remember who they are or where they're from. Dissociative identity disorder used to be referred to as multiple personality disorder, and this is where two or more personalities exist in one person. This, again, dissociation is used as a maladaptive coping mechanism when the person has experienced severe stress and does not want to deal with the stress. The theory is that, especially for children who experienced trauma and also for adults, that they will have a different personality than the one who experienced the stress. It's very critical in nursing that we develop a therapeutic relationship with the primary and each one of the sub-identities in order to properly care for these people. In a depersonalization, derealization disorder, there's a temporary change in the quality of self-awareness. You may feel as if you're outside yourself or feel like you're outside the environment. Big and small may have different contrasts, and you may not be able to recognize yourself as yourself. Assist the patient to recall memories as appropriate. This is called abreaction. Keeping in mind that we are not therapists and, as nurses in our role, not always safe or best equipped to handle the strong emotional reaction that may occur as the patient is recalling these traumatic events. If you are working in that setting and you feel that that's appropriate, that should be something that's discussed with the care team ahead of time. Integration of the personalities is another goal. The nurse must develop a therapeutic relationship with the original and all sub-personalities in order to help them integrate or better feel supported and safe in order to be able to deal with the issue or trauma that each one is facing. And then we want to optimize function, ADLs, and self-care of the patient who's experiencing the dissociation. So for all somatic and dissociative disorders, remember that the goal of the nurse really revolves around developing therapeutic relationships, listen without feeding into complaints, provide care and support without encouraging dependency, encourage participation in activities, accompany the patient as needed for support. The client really must focus on identifying and addressing the source of the stress. These disorders are largely maladaptive coping to avoid dealing with stress, and they need to develop a sense of reality. Thanks for watching.